from the American Academy of Pediatrics.
When it comes to the legal system, children and adults are very different.
That's why the AAP advocates for across-the-board reforms in juvenile justice.
The purpose is supposed to be rehabilitation. The juvenile court is supposed to be involved making sure the young person gets the support they need, but it often functions as furthering their punishment.
Plus, a group of pediatric researchers has a call to action for all of us.
Obviously, there's sort of a social imperative around addressing diversity and inclusion, but it turns out that diverse teams actually perform better and have more innovation and scientific impact.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a conversation about ways to improve the legal system for children and teens.
When I help to take care of infants in the NICU, sometimes one of their parents is incarcerated, and it adds another level of complexity to how we communicate and how the parent can bond with their infant. And while some of my parents are teenagers, I don't know much about the juvenile justice system.
I've only had a handful of patients involved in the system, but my wife, Christy, who does pediatric mental health, often has patients in and out. And my son, Julian, has volunteered in teen court for the last couple of years, which is a community alternative to juvenile justice.
Well, one thing we do know is that kids are different from adults, and their experiences with the justice system should also be very different and based on where they are developmentally.
Sadly, I know the first priority of child health is just not happening within the system everywhere in the United States, and I think we need an expert to tell us how the AAP is advocating for children who interact with the juvenile justice system. Here today is Dr. Elizabeth Barnert.
Dr. Barnert is a pediatrician and associate professor of pediatrics at UCLA who provides pediatric care to youth detained in the juvenile justice system. Dr. Barnert, welcome to the show.
Thanks so much. It's an honor to be here.
So, what exactly is the juvenile justice system? What does the system contain?
That's a great question. And a lot of people don't understand it well. And I think it's a gap in our pediatric training. So the juvenile justice system, or as many advocates are now calling it, the juvenile legal system, in recognition that it's a system that is unjust, is the U.S. legal response to young people who are in conflict with the law. So it involves a young person who has a charge, who is then under the supervision of the juvenile court. Most people enter the system through an arrest. 95% enter through an arrest, but young people can also be referred by probation, by a teacher, sometimes by parents. And then that young person will be under court supervision. They will sometimes be detained. And then if the judge decides that they need to spend time in a facility for rehabilitation and punishment, which isn't necessarily the right approach, then they will be incarcerated in the facility. Sometimes young people will be home under court supervision. And I think it's very important that pediatricians understand that the majority of kids who are under court supervision in the juvenile legal system are actually at home in the community. So this means they're the patients of community pediatricians. I think it's also important that pediatricians understand that a significant portion, about 1 in 10, are in adult facilities. So 17-year-olds, 16-year-olds, sometimes 15-year-olds in adult prisons and jails.
So when you use this term court supervision, I'm not sure what that means. Can you help me out?
Court supervision means that a young person is being supervised by the juvenile court. It means that they will have regular check-in appointments at a juvenile courthouse and often probation monitoring, which means that they have to show up at probation field offices or a probation officer is going to their home. The purpose is, it's the process. It's actually a very hard question to answer because the purpose is supposed to be rehabilitation. The juvenile court is supposed to be involved making sure the young person gets the support they need, but it often functions as furthering their punishment.
So who's most at risk of getting involved in this juvenile legal system in the first place? And once they're involved, how easy is it to get out?
So a lot of this relates to the racial, ethnic, socioeconomic disparities related to developmental disabilities, mental health needs. So young people from minority backgrounds are most likely to be involved. One of the strongest risk factors is history of parental incarceration. And the other very important is crossover youth, so youth who are also in the foster care system. In terms of this question of who's most likely to stay in the system versus get out, I think it's really important that pediatricians sort of understand this in two ways. One is that adolescents, it's normal, healthy for adolescents to have impulsive, risk-taking behavior. That's just part of adolescent brain development. And most young people will naturally age out of behavior that's considered criminal behavior or risky behavior. And the other aspect, though, that I think it's important that pediatricians understand is that when young people do become arrested and they're in the system, there can be this, what I've termed based on interviews with young people in the system, this no exit cycle, where these repeat cycles of criminal charges, arrest, incarceration become very common. So recidivism rates for adolescents 2 years after a first offense is about 75%. And a lot of that it's complicated. Some of it has to do with the criminal identity, the way the young person starts to see themselves, the trauma that they've sustained in the facility, the disruptions in their education, their social fabric. And it also has to do with some basic logistical things like that the court is now supervising them. So whereas their neighbor might not become incarcerated for marijuana use, this young person can because they're being monitored by probation and getting regular urine drug tests.
Do you know, Elizabeth, exactly how many children interact with the juvenile legal system each year in the United States?
On any given day in the United States, more than 47,000 children under age 18 are incarcerated in U.S. correctional facilities.
And does each state deal with the juvenile legal system differently? Are there any federal laws for children that affect the system?
That's a great question and very relevant to AAP advocacy. So it's a state-run system. So the federal regulations are mostly about carrots and sticks. The federal government does put out some guidelines, but mostly it's a state-run system, and we see a lot of differences based on the politics in the states.
And how old do you need to be entered into this system?
So when you ask that question, it makes my heart hurt. Many states do not have a minimum age of juvenile justice jurisdiction. So when I first became involved in this issue in the state of California did not have a minimum age. And my research partner and I got data from the California Department of Justice. And we learned that the youngest child referred to probation in the recent years that we were looking at was 5 years old. A 5-year-old Black child referred for a curfew violation.
Oh my gosh. Yeah, I'm trying to absorb that concept as a pediatrician because it just kind of blows my mind. So as pediatricians, we know that the needs of a 5-year-old and a 15-year-old are vastly different based on their development. Is that sort of developmental factor taken into account in the juvenile legal system?
Another great question. And it really depends on what the laws are in your state. So I think a lot of the people in the systems are doing their best to respond to the young people's needs. And we have seen huge reforms in the last 2 decades in response to the tough on crime eras of the 1980s and 1990s. And that big reform was driven by the recognition that children's brains are different. This is what policymakers were attentive to. This is what was argued in the U.S. Supreme Court. That said, as our AAP policy statement says, locking up children is generally developmentally inappropriate. So even though there's been a lot of progress made of recognizing the developmental needs of children, there is still a lot of misalignment in the response.
And you mentioned disparities in the juvenile legal system. Can you elaborate on those?
Absolutely. So there are profound racial disparities, and there is also intersectional disparities. So youth from racial ethnic minorities are largely overrepresented, but youth who are identified as LGBT are very much overrepresented. And you can see this intersectionality in people with marginalized identities. The numbers are so striking. So to give you a sense, the lifetime risk of imprisonment for a Black man in the United States, for many years, it was 1 in 3. And that number was recently revised to 1 in 6. I was digging back through the data, and I saw that there was a time period around 2005 or so, using Bureau of Justice Statistics data, the lifetime risk of imprisonment for Black men was actually 1 in 2.
Wow. That is sobering. So, when kids enter the juvenile legal system, what kind of representation do they get? Are there lawyers specially trained to advocate for them?
Yeah, that's a great question. Most youth will have access to public defenders, and this is where another aspect of the disparities come in terms of the socioeconomic disparities. So what we're seeing is the kids from racial ethnic minorities who are poor, and a lot of the public defenders I know are really their heroes. They have overburdened caseloads. They're very passionate. They're the same people and organizations that are at the state capitol advocating for youth justice reform, and they love it when pediatricians come. There are gaps in the policies around legal protections. And one of the main findings of my research, particularly on minimum age, is that there's also a big difference between the laws as written in the books in terms of legal protections and legal defense compared to what actually plays out with on the ground implementation. The very important pediatric concept as it relates to development is this concept of what in California is called competency. And in many other states, it's called fitness to stand trial. As pediatricians, we would sort of recognize it as the concept of what is somebody's cognitive ability to provide informed consent. That's sort of the health analog to it. In a courtroom, it means, does this young person have the ability to comprehend what's happening in the courtroom so that they can answer questions appropriately? And so an example in the gaps is that many states will have competency protections, but how they're actually enforced can be quite harmful for children. So for example, there's competency restoration processes. So a young person can be detained for up to years while a jurisdiction is trying to restore their competency and do this boot camp process with them or have them grow or learn enough. And you run into issues not just with chronological age, but with developmental age for young people who have developmental disabilities.
It just seems like there are a lot of areas for change here. Are there alternatives to this system or programs that could replace it?
Yeah, so community-based alternatives to incarceration, the data show that they generally work well and are often more developmentally appropriate and have better outcomes for young people involved in the juvenile legal system. What needs to happen is that health professionals, education systems, child welfare systems need to be supported enough to meet young people's needs outside of a youth justice response. And we need to understand the context of this. It's very easy to speak about this as an advocate. If you listen to everything that's been said so far, you would think, let's abolish the juvenile legal system. And there's abolitionists, that there are people who say this is the only true solution to the system that is so racist and counterproductive. But there are real public safety issues that must be taken into account. And that's where the real tough questions come, because some of the youth do have very serious charges. So there are community-based alternatives that are likely the most appropriate response for the vast majority of children. And then there's a smaller group of kids that I think we all need to put our heads and our resources together to think very hard about how best to support them so that their community can be as safe as possible.
And can you walk us through some of those community programs and what they might look like as opposed to something like incarceration?
Sure. So incarceration is intended to be rehabilitative. So a number of the kids do have mental health or substance use treatment needs. So sometimes this might involve an inpatient substance use treatment center. There are evidence-based programs like multi-systemic therapy that are intensive programs that incur with the family or wraparound services that are delivered in the home. So it's really about getting the young person the services they need. And then in terms of the court supervision, there's things like ankle monitoring that have their pluses and minuses, but keeping kids at home, what the kids would call house arrest, in many cases might be better than incarceration. You notice I'm using the words might be because we don't have the randomized trials on this because ethically they're very challenging to do.
So we've heard some pretty disturbing things from you today about the system as it stands. When pediatricians want to advocate for these children or for changes, what should we be doing?
Well, I think our most powerful advocacy comes from our patients. So understanding what our patients' needs are, what our issues are within our states. I think partnering with the American Academy of Pediatrics state chapters and the youth justice advocacy organizations in your states will likely be what's most effective. There's a wonderful advocacy organization called the National Juvenile Justice Network, NJJN. And what they do is they pull together all the different state advocacy activities. And so they help the state people communicate across states. And so they can help pediatricians understand what the key issues are. So if you're in a state, for example, that doesn't have a minimum age of juvenile delinquency jurisdiction and there's active advocacy in your state, that would be a great issue to get involved in. As you can see, there is a lot to deal with at the same time. So I think it's probably most effective if we let it be known to the advocates, activists leading the charge that we're available to offer expertise, depending on what are the most pressing issues in our states.
And with so many areas for discussion and reform of the juvenile legal system, do you have one last takeaway for pediatricians on the topic? What would it be?
I have two, if that's okay, but they're very simple. One is to remember that these are kids. They're kids. And the more I've spent time with young people in facilities, out of facilities, they're kids who want to do well. They're kids who have kind of struggled in the social determinants of health, and they're exactly the kids who we want to be there for. And this relates to my second point, which is don't give up on them. When I started this field of work, I would hear grumblings like, oh, intractable issue. Oh, you're never going to make a difference. It's such an impossible problem. That's the opposite. There is such opportunity to make a difference, to improve life trajectories across generations. Because this is a legal system, it means that by changing state laws and local policy, and in some cases federal policy, we can actually make a huge difference. And the clinical care, the health needs of these kids are extremely high. So be generous with your referrals, be generous with your attention, because you can make a difference.
Wow. That is incredibly inspiring, and I hope we are all going to go out tomorrow and start making that difference. Dr. Elizabeth Barnert, thank you so much for joining us today.
My pleasure, and I would sincerely like to thank the Annie E. Casey Foundation, who has been doing amazing work in this area, and thank you both for lending your expertise and your insights. You have the pediatrician heart and mind. It's wonderful. Thank you.
To read more about juvenile legal reform, go to our website at aap.org/podcast.
David, what does the term Jedi make you think of?
Ooh, can I use the Force to answer this one? Am I right?
I'm afraid you're far, far away. This is a pediatrics podcast. And in this galaxy, JEDI is an acronym that stands for Justice, Equity, Diversity, and Inclusion.
Just like the new paper in Pediatrics, Justice, Equity, Diversity, and Inclusion in the Pediatric Faculty Research Workforce, Call to Action. This is the way.
To help us get there, we are inviting Dr. Tamara Simon to the show. Dr. Simon is a professor of pediatrics and a clinical scholar with an extensive research history who is now working as a pediatric hospitalist at the Children's Hospital Los Angeles. Dr. Simon, welcome to the show.
Thank you so much for having me. It's a thrill to be here today.
Okay, so JEDI is actually a committee of the Society for Pediatric Research, or SPR. Can you help explain a little of this committee's history in pediatrics and why it was formed?
Sure. We were formed in 2016. I think there was a recognition, like so many organizations, that we needed to do some work around diversity and inclusion. I personally had the privilege of joining in about 2019, and I took over co-chairing it in about 2020. And as you might imagine, we were fairly galvanized around the events of 2020, the murder of George Floyd specifically. And in looking back at my notes preparing for our conversation today, I realized that it really was the summer of 2020 that galvanized us to put together this particular set of work that we're talking about today. And it was really very much a group effort from some fantastic folks around the country who really felt compelled to act.
And before we get into the paper, how does a diverse scientific workforce make for overall better science?
That's a great question. Obviously, there's sort of a social imperative around addressing diversity and inclusion, but it turns out that diverse teams actually perform better and have more innovation and scientific impact. So there's sort of empiric data that is emerging that suggests that the composition of the scientific team can actually improve the impact of the science that's being generated. So we have selfish reasons as scientists to care about diversity.
And what is the call to action that JEDI has been tasked with by SPR?
We came together, again, around the events of George Floyd's murder. And I think that a common unifying theme among some of our lived experiences was having tremendous variability in the support that we received as scientists as we sort of grew our research programs. And I think that as scientists, we can be a little bit egocentric and we can sort of think that it's all about us and all about, the importance of our own research. But I think in sharing stories, we came to realize that there's real heterogeneity in our field and that this heterogeneity has sort of profound impact. I think people think a lot about salary inequity and sort of we know about how salary disparities early in careers sort of compound over time. And I guess for those of us who are motivated around our scientific productivity, we can sort of imagine how disparities in institutional resource and investments might also sort of compound over time and sort of really result in variability in output. And I guess sort of watching what was going on in the world around us, I think we all realized, it may have come out of our own personal experiences, but that we really have a mandate as we become the emerging leaders in our field to turn around and look at the scientists who are coming up behind us, who are having a harder time, arguably, sort of we're dealing with the pandemic. And we really needed to pave the way and make things easier for those coming up behind us, because frankly, it's already a hard road to hoe trying to get that federal funding and compete and be productive scientifically. So bottom line is, I think that all of us probably had some degree of lived experience, but then also really saw an imperative for us to encourage our field to do better by the scientists among us.
And you started to touch on this, but this paper really focuses on 3 domains of change. So let's start with the first, equitable distribution of institutional resources. How can institutions strive to achieve this?
Yes, I think that's a great question. I think we're only starting to scratch the surface of how we can accomplish this. And, the way that we started bucketing resources into things like basic space, like sort of how is space allocated? How are startup funds allocated? And it sort of became pretty clear as we all compared notes that either those policies didn't exist or if they existed, they were not very transparent. And so we thought maybe there was an opportunity if we could start to create a toolbox that we might inspire institutions to look at what other institutions were doing and have a roadmap to follow. And sort of, if you could see how space was being allocated at one place, you might be inspired to put a similar policy into place at your own location. And we also feel like folks coming up in the pipeline are expecting more of this, that sort of these opaqueness in these policies is felt to be increasingly less appropriate sort of amongst younger generations. And so we really sort of felt like we wanted this toolbox to inspire institutions to beg, borrow, steal, copy, but also help establish an expectation amongst earlier career researchers that this is what institutions should be doing in order to ensure fairness, transparency, and equity.
So the second domain of change that you talk about is equitable and transparent salary structures. That would seem to be really straightforward, but what are the barriers to actually achieving this?
That's a great question. I'll be honest, we spent a little bit less time on this because I think that salary is a tricky topic. And frankly, it's covered by many other folks who are thinking about this in pediatrics. What we thought we needed to stand up and say is we think that there's no reason for a research faculty to be paid differently from a clinical faculty. And we think the norm is to sort of benchmark to national norms. And basically, if you're a researcher, you shouldn't be penalized from a salary perspective for choosing to do research over sort of clinical care. The other real issue that is a challenging one is this cap gap that exists for those who are making over the NIH salary cap. If, for example, for a career development award, a 75% FTE needs to be supported by the award, and the salary of the individual is above the cap, then the institution needs to make up the difference. And so there's sort of real issues around cap gaps, as they're called, and how those are handled that are very specific to sort of to the research workforce, I guess I should say.
And lastly, the last domain was increased support and allyship for pediatric scientists, especially those who are underrepresented in medicine and LGBTQ+. What's the best way to truly support this?
That's a wonderful question. Again, I'm going to scratch the surface here. And, I fully acknowledge this came out of the various voices that were represented on the committee. So I think the concrete empirical person like myself was really just focused on how are institutional resources allocated and let's make sure we do the right thing. And there were a lot of voices saying, you know what, there's a lot of intangible support that folks need in order to grow their career. There's issues around sponsorship, mentorship, around being, having your name put out there and having doors open and whatnot. So there was a real push within the group to be thinking about encouraging individuals who are in the field to be allies. So there's a table that was put together for sort of self-reflection for individuals to think about how they can ally with other individuals and just sort of help the person next to them who might be minoritized in some way. But then there are, of course, sort of institutional efforts that can be made with sort of strategic programs and whatnot to ensure that minoritized pediatric scientists are, again, sort of have access to equitable resources.
So for pediatricians, both those within academic institutions and in community hospitals, do you have any last takeaways from this paper that can help them promote this important call to action?
I guess my biggest takeaway would be please use this and please contribute to it. So I think it's a wonderful starting point, but it will only be powerful if we all see it as a collective resource that we need to contribute to, and again, sort of use to promote an expectation within our field that our institutions will implement these policies and sort of work towards equity.
Dr. Tamara Simon, thank you so much for joining us today.
Thank you so much for having me. It's such a privilege. And before we go, I just want to give a shout out to my amazing collaborators, Danielle Serrano, Nancy Spector, Sam Bora, and Jamie Lohr, as well as all the other members of the SPR JEDI Committee. This work would not have been possible without you.
We want to thank everyone you just mentioned. And to read the paper, Justice, Equity, Diversity, and Inclusion in the Pediatric Faculty Research Workforce, Call to Action, go to our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, you know that both of my youngest are now in college at the same time. And I had this experience of dropping Sellers off at school and being so sad because I miss him so much. He's just great company, and I had to walk away and go back to this lonely hotel room without him. And I mean, I'm so proud and happy for him. But right after that, his younger brother came home from his first 2 weeks at college. So I got to hear all about how things were going for him. And it was definitely a pick-me-up because they're just both so delightful to be with.
I'm just not ready for that, David, because my Say Ah has to do with still carrying my child inside me. And I've just gotten to the point in my pregnancy where other people can feel the baby moving, which is really fun. I don't like to be touched like so much, but when I feel the baby kicking, I've started like grabbing hands of like friends and family to be like, come on in here, like you can actually feel the baby. So I don't know how I'm going to feel when they go off to college, but
Oh man, you know what? It's a minute between here and there. I do remember it though. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at a new policy statement about child healthcare financing.
We'll talk to the lead author, Dr. Allison Galbraith. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.